No, no, absolutely not. That's what the same medications that are work for people that don't use drugs work for those who do use drugs. Many of the patients, including those on our trial, are on methadone or buprenorphine. So it's important to establish that there's no drug-drug interactions between the hepatitis C medication and methadone or buprenorphine. And really all the medications that we use now have been studied and don't seem to have an interaction. And certainly from my experience of treating hundreds and hundreds of patients on methadone or buprenorphine, it's not an issue. The deep concern is really the stigma that addiction has in America. So there's a deep fear and a deep misunderstanding both among the lay population as well as medical providers who don't understand addiction, may not have been taught about it, and kind of look at it as a sign of weakness or a moral failing, whereas it's really a medical illness and a chronic disease that affects the brain. It's a disease of the brain that can be treated in various modalities, including methadone, buprenorphine, or 12-step groups, residential treatment. But the fundamental issue is that we don't wait to cure a chronic disease that really is not curable before we address other things. So we don't say, let's treat the addiction first before we find housing, let's treat the addiction first before we treat the diabetes, and in this case, let's treat the addiction first before we treat hepatitis C. That is not evidence-based, and in fact, it actually leads to morbidity and mortality. And myself being, working with this group of folks for 15 years, have seen many people die because of these policies. So there's a lot at stake here. It's growing in terms of the burden of disease. So over the next 10 or 15 years, we need to get this right. There's going to be an exponential rise in the number of people who are dying. So it's really a human rights issue of making sure that people get access. And again, part of it is a lack of education. So we need to educate people and providers. It's a terrible thing that's happening through America with all this increase in addiction, but what has brought increasing awareness as addiction has spread through many communities. And so I do believe that there is a turning point where people are realizing that this addiction is a disease, and there seems to be a greater willingness to implement evidence-based practices in communities that previously had been resistant, so including opening up methadone programs and, really importantly, syringe exchange programs. So we know from modeling work that if we're really going to continue our journey towards eradication or elimination of hepatitis C, we need a combination of increased access to highly effective DAAs or hepatitis C meds, but that needs to be done in combination with opiate agonist treatment as well as syringe exchange programs. I think as more people are experiencing people who have addiction in their own families and their inner circles, that oftentimes will lead to change. And so there just needs to be more people out there telling their stories around addiction. And so we do a number of events where people talk about their addiction, talk about the consequences of addiction, and it needs to be done on a very large scale. Also for people that are in recovery, that are doing well, to be able to share stories about their journey, about whether they have HIV or hepatitis C and how they're overcoming this. And so I am very hopeful that over time, but it's going to take a lot of great collective effort, that the community will get together and begin to treat this in a way. I mean, we've seen this already. We've seen this with alcoholism. We've seen this with depression, where these were, diseases that were treated and shunned similar to like heroin addiction. But now, you can become a president of the United States and, say that you've, been an alcoholic or that you had a history of depression. It's not a stigma. It's seen as a strength, as I really believe. I believe my patients who have addiction, are overcoming this, because many people die, are really, stronger than the average person, because they're battling every day, day at a time, a terrible, terrible illness. We were fortunate to have received a large grant, a $14 million grant from PCORI to really expand these efforts in the real world. So it's an 8-city trial focused in New York, Baltimore, Boston, Rhode Island, Providence, Cincinnati, Ohio, Seattle, Washington, San Francisco right here, as well as Albuquerque, New Mexico. And we're really examining what are the best ways to treat people who are actively injecting drugs, using some of the models that I and others have developed, including models of care coordination, where a care coordinator will help patients through the steps of treatment, helping people overcome individual barriers, address psychosocial issues, adhere to appointments, and also directly observe treatment. The settings will be methadone clinics, but as well primary care clinics, because the majority of people that inject drugs do not attend methadone clinics and are treated in regular clinics. So we're going to be working to treat patients and look at outcomes of adherence and treatment completion, and importantly, reinfection, and looking to see what proportion are reinfected every year, and whether there may be a difference if someone receives care coordination in conjunction with a peer, so someone who's been through hepatitis C treatment, whether that might reduce the rate of reinfection compared to those who don't receive those services. And also conduct a mixed methods analysis, qualitative work, to understand some of the factors which lead to unsuccessful outcomes, such as lack of SVR or reinfection.